Let's roll into breast augmentation. You know, I know breast implants have been out for the last 20 years or more, but what are the different types of breast implants that are available today to the patients?
Well, I'd say in the past 5 to 10 years, there's been sort of an explosion in technology in breast implants in this country, especially in silicone gel breast implants. So the two categories or types of breast implants you'll hear spoken of mostly are saline-filled breast implants and silicone gel-filled breast implants. And saline-filled breast implants are sort of fading out, I think, because they don't seem to perform as well. And the silicone technology has advanced to the point where we know they're safe, and they just produce a better result, in my opinion. And so most people are getting away from using saline implants.
So I know there's a textured type of implant also. Is that textured implant actually proven to help prevent capsular contraction?
Yes, with both saline and silicone implants, we could put a texture on the surfaces. But the reason why we texture the implants is one of the things that the texturing does is it helps prevent capsule contracture, which is where the scar tissue around a breast implant can tighten and shrink down and make the breast hard or firm or distort or change the shape of the breast.
So do you have a favorite implant that you use for most of your patients? I know sometimes many physicians do because maybe it makes a more beautiful look, or it's just a more of a balanced fit for the general public.
Well, I will say there are three companies right now in this country that are approved by the FDA to sell breast implants. There's Allergan, Mentor, and Sientra. And I like to use all of the company's implants, and I like to use the different types of implants, shaped, round, textured implants, based upon the individual patient. But I will tell you that I'm gravitating more toward textured implants, both round and shaped. And I also really love using shaped implants, especially for those patients that want a more natural look, that don't want the fullness of the upper pole, the round, obvious implanted look. I think the shaped implants produce a beautiful result.
And the shaped implant is kind of like a teardrop, right?
It is.
Now, back when those first came out, I understood that some of the complications of that shaped implant was that they could rotate. And is there anything that they're doing now that is keeping that from happening, or was that just a myth?
No, that's not a myth. That's a great question, because a shaped implant has obviously a long axis and a short axis. You know, that's what makes it shaped. It's not round, where if it rotates, it really doesn't matter. But there are a couple of ways that we fight against that rotational thing. And personally, in my practice, I haven't seen instances of rotation. One of those is the texturing. And so in addition to keeping capsule contracture rates under control, the texturing also provides some friction so that implant just doesn't slide around on the tissues. It actually is hard to move those things. And when I'm putting these implants in, if I need to make an adjustment, it actually takes a little bit of an effort. And then the second thing is the way the surgeon makes the pocket where the implant goes. There's a little bit of a nuance in how you make that pocket when you use a shaped implant. And provided that you make your pocket appropriately, it should keep rotation under control.
Now, does the patient get to pick their implant shape, or is that something that you kind of help them decide, or you decide because of the anatomy of their body?
Well, from the standpoint of are we using a round or a shaped implant, that is something that I really rely heavily on the patients to give me input on. So, and a lot of that depends on, sometimes we're just asking questions like, what do you want to accomplish, you know? So we're not asking, or we're not expecting them to come in and say, well, I want a shaped implant right off the bat. They may not know. But through a series of specially designed questions, we'll sort of elicit from the patients what type of look they're going for, and then we can help guide them into the type of implant that might be best to accomplish their goal. Some of the round implants, or all of the round implants I should say, now come with different profile dimensions too. So that doesn't mean that they're teardrop shaped, but some may be broader and wider at the base and a little flatter in projection height, and some may be narrower at the base and more of a high projection. So you'll hear things like high profile or high projection implants. And that's a little bit more of an esoteric determination. Sometimes I don't make that determination until I'm in the operating room. So, you know, for patients to come in and say, you know, I want a high profile implant, that may not be the best choice for her.
I see. So it's June and everybody's hitting the beach. Do women have time to still get busty on the beach?
Absolutely they do. You know, the good news about breast augmentation is that it's a very well tolerated operation, and the recovery times are really pretty quick. Now, you know, the recovery time is sort of sequential. So I tell my patients you'll be bikini ready in about 2 weeks. meaning that they could look good in the beach, in their bikini on the beach, walking down the beach in their bikini. I don't want them running just yet or playing beach volleyball for about a month after the surgery, but they'll still look good at a couple of weeks. So,
what about after they've had anesthesia and they're on the beach, they just had surgery? Do they have to be a little bit more cautious in regards to the sun in their skin?
I don't know that anesthesia itself has any bearing on that, simply because most of the anesthetics that are used for this type of surgery are out of a person's system within 24 hours, and most people aren't going to go on the beach during that first 24 hours after surgery. But certainly want them to be cautious with sun exposure on their skin, just because any additional radiation, ultraviolet radiation, can cause irritation. You may be more prone to sunburn and swelling and those kind of things.
Okay. So let's say a patient comes to you and they say, I want a quadruple D, and that maybe is not in the patient's best interest. So how would you coach that patient into what maybe is in their best interest, or how you would handle it?
Well, personally, I'm someone that doesn't like to just do something like that if I don't think it's in a patient's best interest. You know, if I think that, for instance, the size of the implant may crowd a patient's body or frame size, you know, especially a petite lady that might only be 5 feet tall or 5'2", and if she wants, you know, super large breasts, I think I need to inform her about the implications of that. Now, at the end of the day, I'm also not paternalistic, and so if I've gone through this discussion with a patient and she is duly informed and I'm convinced that we're not doing anything that's going to risk her health or safety, or we're not doing anything that's unethical or will void her implant warranty, like, say, you know, some surgeons will take an 800cc implant, which is the largest that you can get off the shelf available, and stack it with another 100cc implant, or they'll take a saline implant that's only designed to be filled to 800 cc's and they'll fill it to 2,000 cc's. Those kind of things, I think, are, you know, I question the judgment of those. They, right off the bat, they void the warranty of the implant, and that impacts a patient.
Right.
So as long as I'm not talking about doing any of those things, the patient's not requesting those things, you know, even if a patient thinks that, or if a patient requests that I put in implants that I think are maybe too large for her, if she has been properly informed, I'll still do the operation for her.
Okay. So let's talk about the incisions on when administering the implant into the body. What are the options that the patients have?
Well, there are 4 main incisions that have been used traditionally for putting in breast implants. There's around the areola or periareolar incision. There's underneath the breast or the inframammary incision. Then there's in the armpit or the transaxillary incision, and then there's through the belly button or the transumbilical incision. And I'm going to take 2 of those off the table for me in my practice right off the bat, and that's the transumbilical and the transaxillary incisions. I just don't favor those.
Seems like a longer path.
It's a longer path. It's impossible to get saline or silicone implants in through the transumbilical, and really difficult through the transaxillary. Both of those have higher complication rates, like capsule contracture, malposition or poor placement of the implant, and things like that. So the 2 that I favor the most are periareolar or inframammary.
Okay. So then in regards to the inframammary, I understand that's like the cleanest area to a form of entry, is that correct?
It is. I think the studies that have looked at the connection between incision placement and things like capsule contracture, infection, find that the inframammary gives the lowest rate of those complications.
So now some doctors actually do the incision right at the crease of the breast at the inframammary, and some do it a little bit higher. Why is that? Is there a preference?
I think it probably boils down to surgeon preference, but in my case, that preference is based upon sort of a rationale. And I'm one of those ones that likes to put my incision just slightly above the inframammary fold, maybe a centimeter or so. So I don't want it, you know, up on the front of the breast, but I don't want it directly in the fold either. And there are a couple of reasons for that. Number one, I think that fold has a tendency to stay a little bit more moist, and more moisture on a surgical incision means it tends to get soupy. We may have a higher incidence of infection and wound breakdown and things like that. I also think it may tend to get more irritated by a bra band rubbing directly on it. And then lastly, once everything's healed and our patients are in their bikinis and out playing beach volleyball and everything like that, every lady will tell you that, you know, if she's wearing a bikini and she raises her hand to wave at her friends or hit that volleyball over the net, the bathing suit top rides up just ever so slightly, and it may expose the inframammary fold. And if a scar's right there, it's kind of a telltale sign. But you can sort of hide it a little by moving it up on the breast some. So that's what I do.
Well, that's a great explanation. I didn't even realize that thought all the way through all those different scenarios that patients do experience.
Breast augmentation is like chess. We have to think a couple steps ahead.
Let's talk about a patient once she's had her breast augmentation. Is it true that they should always have an MRI instead of a mammogram every year after they've had a breast augmentation?
Well, there's a lot of confusion about that, so I'm glad you asked me that question. This all started back in 2006 when the newest generation of silicone breast implants were approved by the FDA for general use, because before that we had them restricted. And there were a number of restrictions that came along with that approval that came out from the FDA committee that allowed this to go forward. One of those were that they recommended, now they didn't demand or require, but they recommended that patients that have silicone gel breast implants placed have an MRI every 3 years. As it turns out, over the years we've found that that's not a sound recommendation, and I don't think there were many surgeons that even followed the recommendation anyway, but now it's largely been abandoned even by the FDA because MRI is not really a good screening tool like a mammogram is. It's expensive, it's time consuming, and the false positive rate honestly is upwards of 10%, meaning that 10% of the time on an MRI, it would look like the implant is ruptured. We'd go back to the operating room thinking that our patient had a ruptured implant and find out the implant was normal.
Wow.
And so, in my opinion, that's too high of a rate to take ladies back to the operating room just to find out that the operation was unnecessary.
Wow. So if a patient chooses to go ahead and go in for their mammogram, their yearly mammogram after a breast augmentation, should they be kind of concerned and having some fears towards the fact that it could rupture?
No, I don't believe so. And mammography, as opposed to MRI, is still recommended, and the same recommendations by the American Cancer Society exist that ladies should have a mammogram annually after the age of 45, whether they have implants or not. Now, having breast implants in might make it necessary to take a couple of additional views on the mammogram. And I know out here in Southern California, most people that do mammography are well schooled in ladies with breast implants, so they know how to both get the proper films and read the films with the implants in there. And we've not found any significant increases in rates of cancer or problems. As to your question about rupture, a lot of ladies are concerned that the compression of the breast from the mammogram will injure their implants. And I just want to say, just in a short version, that I twist those things, I throw them on the floor in consultation to show patients these things really take a beating. And I don't think that the force from compression is going to come anywhere near injuring their implants.
Right. Well, I had my first set of implants like 20-some years ago, and I was told that they were going to last for a lifetime. Well, 4 sets later, I found out that is not necessarily the case. But there's a lot of patients that when they're going in for their very first set, they're thinking, oh my gosh, I have to have this replaced every 10 years. Is that true?
Well, yes and no. And I think as you found out, the breast implants they may not be a lifetime device. They're man-made devices. There are things that can go wrong with them. They can rupture. We can have capsule contractures, as we've talked about, infections. Or ladies can, have life events like pregnancy and breastfeeding and things like that may change the breast. All of these things may necessitate or cause a lady to want to have her breasts operated on again in the future. So the way I counsel patients on this issue is that, you should not expect these implants to be lifetime devices. You should not expect that this will be your only operation on your breast. But then again, there's no set time course that you have to have your implants rotated like your tires or your oil change in your car or anything like that. And 10 years, everybody talks about that. I'm not sure precisely why that number has come about, other than to say that most companies' warranty programs tend to expire at 10 years. And that may force some ladies' hands into saying, well, I'm going to get my implants replaced so that I don't go without a warranty. And then there has been a study that's shown that the incidence of reoperation on the breast increased at 10 years. But again, that's reoperation from all comers. So even ladies that just electively decided, my breasts are a little saggier now that I breastfed, I'm going to have my breasts redone. Has nothing to do with the implant failing. So we want to make sure we sort of iron that out.
Yeah, and that's a great scenario with a mother that's breastfed and has change in her breast. But also, I think that when you have breasts at a very young age, you may choose a large, high profile. Well, 20 years later, that might not be your personality of how you're wanting to present yourself anymore. And so you can kind of scale that down a little bit, and it'll be a little more conservative because you have that opportunity.
That's a very good point. And I have a lot of patients just like that who had a breast augmentation in their younger years that suited them for that time in their lives, and then later on they felt that it was too much for them, or they wanted to make a change to make things a little bit more modest. So that's a very common scenario.